great. I just want to say how appreciative I am of having the guidelines shared with us, but also, the evidence and also the thought processes that went behind the decisions to get to the new standards of care. And also just to say thank you because of all the motivated hard work that goes just into the guidelines, but also into your role in developing this curriculum. So thank you so much again. Well, we have about 20 minutes for questions. There'll be a wrap-up at 5 minutes to the hour. Drs. Knudsen and Massey will return. We'll invite all the speakers today to come up and take a microphone. And there are a couple of floor microphones. If you choose to use them, feel free to direct the question. Feel free to, if it's your practice to share who you are and what you do, that's interesting, but you can also just go straight to the question. We'll do our best to field them. If you're not using the microphone, I'll ask the person who's answering the question just to repeat the question sort of for audibility reasons. So please, floor is open and the panel is yours. Yes?
You are so funny, by the way.
Hi, it's Dr. Andrea Landis. I have a question, I think, for the last speaker, Dr. Leibowitz, I think.
Yeah, that's me.
I have
Hi.
a question. One slide is sticking with me. And just because there was no research that was listed or cited at the bottom, no endnotes. The one about recommending menstrual cycle suppression as opposed to puberty blocker. So I just want to know, like, where were the studies that were kind of supporting that? And maybe I read the slide wrong.
The slides were the slides could have citations on them, but they're in the chapter. So all the citations that we do have for the menstrual suppression particular one are in the chapter.
That was just new to me, so I wasn't familiar with that research.
Well, if you think about it, so menstrual suppression, just real quick, and I feel like I'm a little out of my league, not out of my league, but out of my lane, because we need the adolescent medicine primary care docs to talk more about it. But what I would say is if you've gotten to a point where a young person is experiencing menses, they are somewhat already past the ideal opportunity for starting blockers. That doesn't mean that blockers are not useful. It means that sometimes menstrual suppression could be used. The goal of the recommendation is not to say use this instead of blockers. It's to say this is an option to consider. And also, it's, I find, a helpful one for parents and families who are more afraid. So, and it helps provide some degree of the adolescent feeling affirmed, because that's a very negative experience, and allows us to then do the mental health, psychological, family-based work to get the parents to a better place. Yep.
Thank you.
I'll read that chapter.
Yeah, I don't know if that helps, but the citations are definitely in the chapter.
Thank you.
Sure.
Hi, thanks for all of your talks today. Perhaps it's another adolescent question. I'm a family doctor, and so a lot of times, actually, I'm in a resource-rich setting in the United States, and I find that sometimes patients and their families can more easily access me than they can mental health services. Mm-hmm. And a lot of times I feel very comfortable. While I don't have as much dedicated time, I can schedule, return visits and stuff. But I was wondering if you could speak more candidly or to your, perspective and opinion about how we approach that situation as a non-mental health provider, but someone that does, I don't know, because I feel like I'm doing mental health all the time.
Right.
But I want to kind of just hear candidly, because I read what the recommendation said.
Right. Thank you. So I think that's a great question, because then there's this whole question of involving a mental health provider, and do we need a mental health provider? It's not easy to always access a mental health provider. But then on the other hand, the pediatricians and primary care docs have 20 minutes to do their vaccines, their asthma check, their the physical. So how can you possibly get into all of this? And that's where the balance comes into play. I also think that within our disciplines, we are all have some degree of competence and training in another discipline based on what experiences we've had or what training program we went to, or whether we just are used to or comfortable with that. And so this isn't to say that primary care docs can't do this. It's to say that different primary care docs have different blind spots. Not all primary care docs are comfortable working with mental health issues, and unlike you, which is why it's amazing that we have so many primary care docs who are so fantastic at doing their jobs and can really dive in and understand what family dynamics are at play, so that you can identify. Who said it earlier? Like I know like a little about everything. Like you then know when you probably need to escalate and when not to. So this is to provide you with the gold standard, and based on your level of experience and your level of training, try to meet the needs of the families as best you can.
That's good. Over here, please.
Hi, Ashley Fisher. I'm a pediatrician from Central Illinois. So I think a lot of the guidelines talking about this comprehensive biophysical evaluation, great. That's a very, I feel like, umbrella thing. And in case of practicality, so I come from a very resource scarce area, so a lot of this tends to fall on the primary care team. Is there a framework, or is there something you recommend to kind of make sure we're hitting the things we need to hit on that, like question sets or things like that?
Read the chapter.
Fantastic.
Over here, please.
Thank you, conferencist, for this amazing time with us. I'm Gustavo Perdomo. I'm from Bogota, Colombia. I'm an attending psychiatrist. And we have there a problem with the diagnosis of gender dysphoria because, of course, we are a developing country with very high failures in our health system. And there is like the requirement of the diagnosis for getting into gender-affirming processes. But also we had the trans community that has been instrumentalized, has been violented by mental health providers. So we had like this conflict between establishing a bridge and the diagnosis is very hard for this community, but it's also the ticket for the process. So we had a huge conflict, and we are trying to gather around in order to establish the bridge. But I don't know if you guys have some kind of recommendation. I know that Dr. Leibowitz has said about the ICD 11th version. In Colombia, the health system is built in the 10th version. So it's hard, and I don't know if you can give us some advice for that. Thank you.
I think that is always the push and push here is like definitely they need the diagnosis to get the services, but a lot of time having that diagnosis really stigmatizing the community and the client that we have. I think that I would explain to especially to some of the teenagers, is let them know how this imperfect system, what kind of support that we can help them. So I try not to help them think how they stigmatize, let them know the stigmatizations, how that will be maybe affect them. But at the same time, I will try to understand that how this may help them to get the support that they need. Even though maybe temporary having this an imperfect system, and that, unfortunately, that is how we struggle with is in Canada too. Yeah.
Okay, thank you.
Thank you. This microphone, please.
Yeah, I actually had some questions about speech pathology. I'm a family nurse practitioner working in adolescent gender care, and lots of voice dysphoria complaints. And curious about how to guide my speech pathology colleagues toward training to be able to deliver that care, if there's like certification or training they can do. Also curious about online resources for patients that are good and reliable, and whether or not you would suggest that. And then the third question is around diagnoses that might get more insurance coverage than other diagnoses in terms of referral to speech pathology in the U.S.
Training, online, and funding.
Training there. I'm involved in training about 100 people a year. There are a few courses out there by those of us who have a lot of experience, and they are developing a mentoring program through GEI that will be up and running, and will be a great way to connect people with people who are who've been doing this work for a long time. So I can talk to you
Okay.
about the courses. What was the next?
Do it yourself.
Do it yourself. I absolutely encourage people to do it themselves.
Okay.
You know, why am I the perfect person? You know, or a trained professional.
Is there
I mean,
damage
of course
that you
want.
can do?
Great.
Okay.
Yeah, I mean, if there's, so of course, with the caveat that yes, you have to, be aware of whether you're feeling strain or discomfort, then that is a problem. But some people do very well without strain. And a lot of people don't have the resources. So we need to get off our high horse and say, hey, there's some, and there are some good resources out there, whereas for a long time there weren't. So I tend to tell people about a YouTube channel called Trans Voice Lessons that is a lot of good information that is not unlike what a lot of professionals do, that is done by a trans woman. And then, what was the third part?
How to get funding for SLP? Any clues, any suggestions? Is that correct?
Oh, insurance.
Yeah, so like a diagnosis.
Coding.
Yeah.
It was coding, I thought,
Or
of the.
diagnoses, yeah, for insurance.
Yeah, it's kind of a sticky issue because, there are people sometimes use codes that are not appropriate. And I think in our field, it's really important to be teaching the insurance companies what is medically necessary. We need to say that these gender codes are medically necessary, not, oh, you had hoarseness on day 5. Therefore I'm gonna say that you have hoarseness the whole time, so that you're gonna get covered. I don't think that does anybody any service. I think what does a good service is to keep pushing that training is medically necessary. So there are codes, and again, I can give you those. Thank you for all those great questions.
Very good. Thank you. This microphone.
Hi. I'm Claire Roden. I'm an adolescent medicine attending in Hershey, Pennsylvania, which is like academic, also rural, so very fun. Woohoo. So my question, as an adolescent medicine person, I'm sort of like a third endo, a third GYN, and a third psychiatry, and like not perfect at any of them. But I find with a lot of my families, especially around menstrual suppression, I just talk about like, would I deny your child this if they were coming to me for some other problem? Would I not do this in your child if they were cis? I mean, if there's no, then like whatever, don't get too excited about it. How often do you find that, like, I almost call it like a rights-based approach? Would I do this in your child if they were cis? Would I deny this to your child if they were cis? If the answer is, I would still do it, I still wouldn't do it. Does that come up for anyone else around periods? Like, specifically periods and contraception?
Can you amplify a little more about the period contraception? So you're saying, like, would you do menstrual suppression?
Yeah, so I see a lot of people.
Would you do it in person A? Would you do it in person B?
Yeah, like.
Or not? Is that the?
Yeah, so a lot of my trainees, I guess, a lot of my families are like, oh, we can't do an IUD because you're trans. It's like, well, no, we totally can. We totally can. But a lot of my trainees might have some hesitancy with this, or their families may have some hesitancy with this. So I
think that the goal is to sort of know all the options that can help someone, talk about them, say the risks, benefits, or the pros and cons, and then if I don't know that I'm quite following, because I think that a cycle for a person with dysphoria is experienced very differently than a person who's not. So that's why it's hard to like completely. I know you're coming at it from like an equality, equity standpoint.
We should do this for everybody who wants it. The end.
Yeah. I mean, I guess as someone who doesn't know how to prescribe menstrual suppression, and I always tell my patients, like, you do not want me doing that.
Come to me.
Yeah,
It's
like,
fine.
you know, as someone who's, I would refer them to you. I think that you just, there are some kids that, like, the procedure of an IUD is too traumatizing for them, and for others, they're walking in the door saying, give me my IUD now. So I think it's just a pros, cons discussion, and take it from there.
Does it help with families if you frame it that way? Like, do you ever find that it works, it doesn't work?
Are you saying, like, there are parents that are against
Yeah.
menstrual suppression?
Oh, yes.
Yeah.
They show up in my office every day.
I know. So from my perspective, I think, like, when I frame it next to hormones, usually they're like, okay, let's do menstrual suppression. Like, I mean, just like, it's just all about, it's all about the delivery and the messaging. Yeah.
Okay.
I
Thank you.
think I would add, like, sometimes let the parents know in action, sometimes can be just as damaging and making the wrong decisions. So I think it's important to let them know if we do nothing, how would that affect the kids'
Yeah.
mental health?
Yeah.
How would that worsen the kids' gender dysphoria? And how would that affect your kid going to school with the anxiety, depression? I think more globally, let them know the big pictures. Sometimes that may shift the way they support
So
on this.
inaction can be more harmful than other
Yeah.
action. Yeah, it's a point. It's not
Yeah.
neutral
That's a good thing.
framing. Great. And this
But
microphone,
are you
please.
going to have some people that are unhappy? Yes.
Someone.
So we'll, our questions, we'll keep them brief, and just for the 4 people now at the microphones as we get close to wrap up.
Thank you. My name is Bonnie. I'm a marriage and family therapist in San Francisco. I work with adolescents. And my question is around binding, and you had mentioned around speech pathology that does affect the voice. And I just would like a clinical overview, as brief as you can make it and as clear, how that affects the voice so that I can repeat that to them when they have concerns.
A couple things. Thanks for that question. Hello. One, there can be tension, upper body tension from wearing a binder, and 2, shallow breathing. And so it's training breathing while binding, so it's sufficient, because that's another way, this kind of glottal fry voice, it can be from binding too. Discussing that and showing exercises that people can do, like when they take the binder off at home in private, stretches that they can do and things like that. I'd be happy to talk to you more about it privately
Oh,
too.
okay, great. Then I won't take any more of your time. I'll ask you later.
Good, thank you.
Thank you.
And this microphone, please.
Another question about adolescence. I am a nurse practitioner, trained as a nurse midwife, working in Seattle, and I've been working for about 4 years doing gender-affirming hormone care with people 16 and older, but I just got hired to work with adolescents, and they had to change the bylaws of the organization so that a nurse midwife could do this role because they don't have the full training of a family nurse practitioner. And I'm wondering if there's anything short of me going back to grad school again, which I don't want to do, that I can do to bulk up and expand my knowledge of development and family in a way that would be useful.
That's such a good question. First of all, I'm going to make an assumption, which I know we're not supposed to do, but my assumption is actually probably one that might be right. Most, if not all, the people in this room have an in-tune sense of dynamics and the complexity of adolescent angst and identity development, and when things are interfering with other things. So it would be wrong for me, Scott Leibowitz, to say, you have to do this, to do that, to get competent in this and that and that. And that's not something I think I would ever want to tell someone. What we feel is important is that you know what the complexity is. Clearly, as working with adolescents and families, anyone working with adolescents and families knows that this is not cookie cutter, knows that it's very individualized, and as you gain more experience, honestly, just having these principles in the back of your mind, you're there to navigate the decisions with them and really work on recognizing when is it a chess game and when is it a checkers game. And if you can recognize that, and that it's okay to sometimes play chess to get to the end result of authenticity, then you're good to go. And then like whatever opportunities, if there's training courses or continuing ed courses and conferences, like I think there's a conference called AFTA, the American Family Therapy Association, that I personally would want to go to also. Like I feel like as a psychiatrist, I am not like an LMFT, a licensed marriage and family therapy. Like they have far more competence in this than I do, and sometimes I get stuck. And I'm a psychiatrist, so I just want to refer to my colleagues at that level. So you just know it's more about knowing your blind spots and then working to mitigate for them.
So I think you're answering my question in terms of how to provide quality care, which is the most important thing. But there's this little asterisk in my mind that's like, is there a box that I can check that'll protect my organization from legal and
You
crazy
came to
people
GI
attacks?
and you learned the SOC 8.
Okay.
Yeah.
Did it.
Cool. Thank you.
Yeah.
Let's get the certificate up. Okay.
Hi.
This microphone.
Hi, I'm Chris Sexton. I'm a psychologist in Kansas City, Missouri. Dr. Wong, you had a finding on your slide that I think by age 4, gender is crystallized. Maybe that's not the term. And then, Dr. Leibowitz, you kind of presented the 3 trajectories, pointing out that all of those are pathways that are perfectly reasonable, including one in which there's absolutely no gender incongruence until puberty or later, right? And that's something I'm often asked by parents is, oh, well, they didn't, at 4, they were definitely, a cisgender child. And so I just wonder if you can speak to those 2 findings and how we reconcile those. Both of you.
Yeah, we could both do it.
Yeah.
I think for me, a lot of times that the parent will say, hey, I never seen this happen until much later. I really think that in our assessment, I wouldn't want to, because a lot of time the kids, they have the feelings. Research showing many of them, they do have the feelings, but they don't have the language to know what their feelings meant. They thought they can get rid of it when they get older. They thought that if I be girly enough or boyish enough, eventually that feelings will go away. So it's not unusual that feeling doesn't surface until adolescent because they have to deal with it because my chest is coming, my period is coming, right? So I think that is one part of it. I think it's important in our assessment sometimes or answering the parents, let them know sometimes they do this, baby, they don't want you to know because they're afraid to get kicked out of the house. They really don't want to hurt your feelings.
Although at times the child also will say, I didn't even think about gender until
Yeah.
15 at drama club. And,
Well,
I'm just saying, that happened last week.
I know. I agree with I agree with everything that's been said. Like it's a very common experience what Dr. Wong is bringing up about like the suppression of an experience or not having the language or not having the awareness that one could be different. But at the same time, there are the whole point of that slide in the child deck, I think, is to show that is historical theories of gender development that were based on false premises of the binary.
Yes.
And cisgender, cis-normative expectations, so that the past studies, that what we know about gender identity development are somewhat flawed, right?
Yes.
The point being, though, there are families that do come in where it's not what Dr. Wong is experiencing, it's what you just said. And what I would do is I always, with the parents alone, never in front of the adolescent, ask them if their parenting reinforced stereotypes or not. And then I list what those stereotypes are and get a sense of like what the parents think of their parenting and the environment that the kid is in. So it's very different when you have a kid that conformed to their stereotype because the parents are like, you're a girl, you have to do this, and you're a boy, you have to do that,
Sure.
versus other parents that come in and saying, I didn't want a girly girl, so I actually really tried to avoid gender stereotypes with my kids, right? And so then you have the kid that comes in and says, my mom made me wear a dress. And then the mom, and in that scenario, I actually feel like sometimes I'm going to ally more with the parent and challenge the kid a little bit because the parents seem generally baffled about what's happening and purposefully were approaching parenting from a place of deconstructing the stereotypes and deconstructing the binary. And that's why we have to just know who we're working with. So.
Thank you.
Thank
And
you.
final question here, please.
Hi, I am a clinical social worker, so I'm quite interested in therapeutic modalities that can support myself working with trans clients who are struggling with dysphoria, waiting for surgeries, trying to make it through day to day. And I'm curious about the modalities of therapy that, like, what's out there at this point.
Adults? Are you talking about, say, adults?
Oh, sorry. I guess like adults, teenagers. And also, I'm quite interested in the experience when working with the family is not actually possible. Because I understand there is attachment-based family therapy.
Yeah, I think, again, the standards of care do touch on this issue, that there is really a heterogeneity about different approaches that people take. Like, I know from my own background, I am interested in attachment and trauma-informed kind of ways of engaging with people. So, I end up thinking about different kinds of problems and approaching it with an eclectic approach, but keeping in mind that there is some underlying factors like the minority stress and trauma related to that colors it. But you certainly can try your best to utilize with patients, well, what are some practical, and that's why we're talking about, what are practical ways that you can manage your dysphoria while you're waiting for your gender affirming, let's say, chest surgery. Mm-hmm. So, and that's, it's actually quite problematic for some individuals who go on to, let's say, masculinizing hormones, but they have a visible chest. I'm not in that position, but I can fully understand, and they are actually being pretty reality-based when they're saying that they get looks and sometimes they get confronted, and that's where I think we need to have some helping them be realistic around the world that they're dealing with and trying to navigate communities while they're waiting for what can be, and it's true, life-saving surgery. Like I've had people, their lives transform once they get the chest surgery out of the way. And I think that's why the standards of care have also adjusted with the realization that holding people back from that. So I think it ends up being a mix. Like you may very well find that in some cases doing like a CBT approach can be helpful if their anxiety as you're talking to them is clearly problematic and holding them back. But you just have to adjust and get to know the people that you're dealing with and know the community and what's available. So I think that's also the combination, because I end up getting to know the group leaders in when I refer them. Go to this support group. They'll talk to me about what it's like for them as they're trying to introduce them to the support group. So I think, I don't know if I'm answering your question fully, because I don't know what community you're dealing with. Sure. But I think that's why I end up using multidisciplinary approach, holding their hand, allowing them to have some patience and some guidance as they're waiting for these gender-affirming treatments to start to work for them, but being aware that there may be some superimposed anxiety disorder, depression that may need its own individual treatment too.
Yeah, I guess I'm understanding there's less research done on this. Like there's no best practices around both that and also exploring gender identity. Like I understand we're not trying to diagnose, we're not trying to tell people what their genders are, but you know, like as a trans person in the community, you know, it's a pretty difficult process in figuring it out. And it'd be nice if like the medical professionals who helped me in my life had knowledge and could guide.
It's a challenge because when you're talking about evidence-based treatments, right, none of those have been gender affirmized. I made that word up. But I feel like because you don't want to, like if you create like a gender evidence-based treatment, in some way, I think that that's not the way to go either, because then you're saying that everybody benefits from this sort of gender focus when not everybody needs that, but rather it's about adopting existing known treatments that do have evidence for all people and ensuring that they are gender affirming for all people. And I think that the problem is that evidence-based treatments, like we don't focus in on gender with cis people, and we should. So just to help cis people develop a solid sense of their own gender identity and gender expression and how that intersects with their emotional and psychological well-being. So I don't think it's any like extra treatments that we need to come up with. It's more we need to take that what works and make it gender literate or gender affirming.
Yeah, which I think would be great if there was research to show what that looked
You
like.
just found your next research idea.
Okay.
Yeah.
Okay.
Thank you. Thank you very much. Dr. Knudsen.
Great, thank you. I have two quick messages. And before that, I want to thank our panel and all our faculty for today. So I'd like to give them a round of applause. Thank you. And I'd like to thank Dr. Dahl for being an excellent moderator today and host. And Dr. Dahl will be back tomorrow speaking, doing a presentation with Dr. Metzger on hormone therapy. So my two messages. One, tomorrow you start at 8:30, not at 9 o'clock, and it goes to 4 because we start with Dr. Levine at 5:30. So we want to get enough time for everybody to kind of have a break and get down into go into the plenary room. So we have, so you have a bit of a break. The other thing is that if people don't know, we've invited you to a party, and the party's happening right now, and it's till 6:30, and you're all invited, and it's in the creation room on the 6th floor, so it's on the 6th floor of this venue here going towards the hotel. So we'd like to invite you there, and we hope that you'll join us. So thanks again for your attention and your time and your questions today, and we'll see you at 8:30. Thank you.